just grounded for creating a space for us. I'd like to welcome you to the next session and to Donna Cohen. Donna Cohen is the director of meerkat, and Donna has over 20 years experience in research, policy development and project design, implementation and evaluation of higher education and health service sectors. And before we started, I talked with her, and she's worked across lots of different areas, from academia to policy development and all of organisation engagement. So I'm looking forward to hearing from her. So please welcome Donna.
Thank you, Karen. So today it's a wonderful segue from the last session. I'm going to tell you about an online tool that we have developed which significantly expands the utility and value of program logic maps and indeed any type of process map. And through that expanded utility actually helps to address one of the key issues that managers and evaluators face, which is how to engage staff in evaluation activities and in quality improvement more generally. So in terms of the structure of the presentation, I'm going to start off by just telling you a little bit about how it is that we came to be working in this space. So, what was it that drove us to look for some alternative tools? And then I'm going to tell you about the particular case study for which we developed this new tool. I'll give you a bit of background about the case study, tell you about the evaluation problem that we encountered, the solution we developed, and then give you a little bit of stakeholder feedback about the solution, this being an evaluation conference. Of course, we evaluated it. And then finally, I'm going to tell you how we've taken that bespoke solution that we came up for that particular case, and we've turned that now into an application that has much broader application. So I first worked with program logic maps maybe a dozen years ago, but I didn't know I was working with program logic maps. I didn't know there was such a thing. I didn't know there was a name for it. I was the director of a strategic projects development unit in a faculty at a Victorian university. And myself and my team, we would frequently have to come up with funding submissions for new initiatives or implementation plans for those initiatives. And it just actually made sense to us to model how the inputs and resources that we needed for that initiative would then flow through the activities to generate the outputs and outcomes in order to achieve the objectives of the initiative. That just made sense. I didn't know it had a name, but it was a model that made sense. And indeed, that is what a program logic map is. It is a model of how a system works. And as I've indicated there on the slide, one of the beautiful things about program logic maps is that they are scalable. You can create a program logic map for a system, for a program, for a project, or indeed a process. Of course, they work precisely because they do help to describe the relationships between all of the components of the system. But they do another lovely thing, which is they help to reveal the assumptions on which the design of your system is based. And if you are a program manager, this is very important, of course, for risk management. So even though I didn't know the name of what I was doing, I did understand the value of program logic maps for program managers, namely as the foundation for project planning, but also, if you choose to use it for this, a roadmap for program implementation. So fast forward a number of years, I go out and become a consultant, and together with my colleagues, we start putting in bids for projects to develop evaluation frameworks for clients, and then I found out what a program logic map is, and then I also discovered that it is a tool for evaluators, and it helps you to identify, as you know, evaluation questions and indicators by which you would measure them. Now, once you start working with indicators, the first thing is that sort of rush, that buzz, the fantastic potential of indicators, and then very quickly you realize that there are some downsides to indicators as well. So the good, of course, is that indicators do assist you in evaluating the success of whatever it is that you're evaluating, whether it's a whole organization or some part thereof. The thing that you do learn, though, after you've generated quite a number of indicators, and I've probably generated my body weight in indicators over the years, is that not everything that can be measured is important, and the flip side of that, not everything that is important can be measured. And we particularly found this because we do a lot of work in the health and human services area, in higher education, and these things are particularly true for those sectors. So you go out there and you generate all of these indicators, and you feel really good about yourself, and then you come to realize that they're not actually adding a lot of value necessarily, and that in fact the most effective indicators are those that are pointing at one or more of the critical success factors of your initiative. The problem was a lot of the evaluation frameworks that we were developing were for new programs where you don't know the critical success factors, so you have to go and generate a lot of indicators and then hope that you will eventually correlate your findings with what's important and work out which ones are the right ones. So that's the good and the pointless. The bad is that measuring indicators can in fact lead to perverse outcomes and unintended consequences because staff will tend to bend their behaviors in order to give you the best indicator result. And I like this particular quote attributed to Dean Spitzer: people do what management inspects, not necessarily what management expects. And this is very true. So over the last about 6 years that we have been working in this space, we've encountered most of these sort of pitfalls and pratfalls of indicators. And this has caused us to start looking to find out, is there something else that we can do in terms of self-assessing, particularly in the health and human services, particularly in the higher education sector, that is a little bit more informative and revealing about what's actually going on in that space. So what I'm going to do is tell you now about the case study which caused us to develop our new tool. And the case study has to do with the professional education, professional training for health professionals. So just a show of hands, how many of you in the last, say, 2 months have been to see any type of health professional? Doctor, nurse, podiatrist, physio? Yeah, look, probably most people. I wonder, did you know that in order to become qualified health professionals, they have to undergo training that includes both a theory component and also what's called a clinical education component? And the clinical education component is exactly what the name suggests. It's when they go into a clinical environment and they work with qualified clinicians and with real patients, and they learn and practice their clinical skills. Now, the clinical education component can be quite a significant component of a course. A typical health professional course can be 3 to 5 years in length. The clinical education component can be anywhere from 20 weeks in a 3-year course, bearing in mind those 3 years have about maybe 80 weeks of study. So 20 out of the 80 weeks could be clinical training, up to 96 weeks out of, say, 140 to 160 week course. So it's significant. It's a significant proportion of what they do. Mainly it's done in public hospitals. In Victoria, for example, 70% is in public hospitals, but now there's a bit of a push to move into the non-hospital sector. And it's big. Okay, in 2012 in Victoria, more than 1 million clinical placement days. And in 2015, that's probably about 1.3 or 1.4 million clinical placement days across all the health professions. So this is big. But here's the interesting thing. It's the education providers that offer the degrees and, of course, award the degrees, but it's the health services that are responsible for delivering the clinical education. Why is this a problem? Because each of these are different organizations. They all have their own circumstances. They all have their own attitudes and approaches to education. So we end up with significant variability in the quality of clinical placements. This is a problem because we expect every health professional who is qualified to have achieved the same high standard in their delivery of clinical services. So in about 2007 or 2008, the Victorian then Department of Human Services, now Health and Human Services, they set up an initiative to address this question of quality in clinical education. And they started by asking this question: what is needed to create a positive learning experience for entry-level learners? Now, my consulting business won the contract to develop this. The initiative became known as the Best Practice Clinical Learning Environment, BPCLE, trips off the tongue, the BPCLE Initiative. And in the first project, we developed the BPCLE framework, which is a framework of 6 elements that are the essential underpinnings of a quality clinical learning environment. In subsequent projects, there were about half a dozen projects. In subsequent projects, we developed a performance monitoring framework. I told you I developed my body weight and indicators, 55 indicators that go with this framework, and also a resource kit to assist health services to actually create high-quality clinical learning environments. Now, this next slide just shows you the framework on a page. The detail is not important. What I just want to point out here is here are 6 elements here, and if you can read any of those, for example, an organizational culture that values learning, that's element number 1, you can see that these are basically high-level objectives. And then the framework, in the text of the framework, it goes on to explain what we mean by each one of these elements or high-level objectives, and you can consider these to be perhaps sub-objectives that explain what we mean by this. So as I say, we developed the framework, we validated the framework, we made our indicators, we did our resource kit, and finally the department said, enough with the development. Now we have to implement this framework. And again, we won the contract to do this. And so it's like, right, now, how do you take theory and translate it into practice? So we came up with the following scheme. First, health services should apply the guidance of the framework. And to do this, they would first self-assess against the framework, and then they would develop an action plan to address any problems that were identified. All good? Fine. Second phase, implement their action plan. Third phase, collect, analyze, and report data against the indicators for which they might need to establish or refine their data collection systems. Now, we looked at this and we said, oh, gee, that looks fairly familiar. Of course, it is a plan, do, review, quality improvement cycle, where the planning phase is the self-assessment and action plan development, the doing phase is action plan implementation, and the reviewing phase is everything to do with the indicators. But knowing that it was plan, do, review, quality improvement cycle didn't really help us with our problem, which was how do you self-assess against the framework? So we said, okay, we've got 55 indicators. Maybe they could measure the indicators and we can work out how they're going with that. And we said, are you kidding? Do you really think health services will put in place 55 indicators? Well, of course they wouldn't. We said, well, okay, let's choose the ones that are associated with the critical success factors. Except it's a new initiative. We didn't know what the critical success factors were. So we said, you know what we really need here? What we really need here is like a checklist of, you know, what are the inputs that you need for this? What are the processes you need for this? What sort of outputs and outcomes? Sounding familiar? Yes, of course. We realized we had that, and that was in the form of the program logic maps we had developed when we were creating our 55 indicators, which, of course, as I said back at the beginning, is basically a roadmap for implementation. Eureka, we said. We have the roadmap for implementation. Let's self-assess against the roadmap. So as I say, we had created logic maps for each of the 6 elements. This is the logic model for element number 4. We run our logic a bit differently to the convention. Our inputs are at the top. Then these are the processes. These are the outcomes and outputs. And the objectives are the purple diamonds at the bottom. So we had these beautiful logic models. And we thought, you know, here's what we'd like to do. We'd like to use these as some kind of interactive tool. And we'd like the group to sit down and to talk about each of the inputs and the processes and the outcomes and say, do we have it? Do we do it? How well do we do it? And so on. If you've ever drawn a logic model, you know there's plenty of software out there. We've just been talking about it. Plenty of software to help you draw the logic model, but no software to help you interact with the logic model. And this is what we wanted to do. So I'm going to focus on this little part of the map over here. So let me show you what it was we wanted to do. We wanted it to be that if you were to click on this particular item, a dialog comes up, which asks you a question. For this input, does this input exist within your organization? Suppose you answered no, and click OK. You get a black halo around the item. Okay, you're sitting in a group, you're talking about this, so this is part of a team-based discussion. You click on another item, it opens up a dialog box. Let's say you say yes. Now you get a rating scale of 1 to 5. If you rate it 1, 2, or 3, in other words, average or below out of 5, let's say 2, and you click OK, then you get a red halo around the item. Then you click on another one, and this time we'll rate it yes, and we'll rate it either 4 or 5 out of 5, and click OK, and now you get a green tick. Let's suppose as you're going through the discussion, you open up an item and you go, actually, this doesn't apply to our organization, so you click not applicable and click OK, you get a grayed out box. And when you complete the entire map, you get an instant snapshot of where the problem areas exist. The aha moment. And we call this map-enabled experiential review. Okay, so that was the idea. So now we have to pilot this. So what I've just shown you is actually the online version, but we originally created what we called the MER tools, the prototype MER tools in Excel. You've never seen Excel do this before. My husband is a whiz with Excel, and he's the one who came up with the idea of how to do this. And we developed these tools, and then we went out to pilot this in 11 health services right across Victoria. Everything from the largest metropolitan health service out into the regional areas, community health, general practice, aged care. We went to a lot of different health services. We wanted to observe how do they use the tool? Do they like the tool? Was it useful for them? What behaviors were we seeing there? So basically this is what we saw. First of all, it provided incredible structure for the conversations, and they turned into interdisciplinary discussions. We thought they would all be siloed conversations, just the nurses talking or just the doctors. No, they got in a room and talked to each other. It revealed the mechanics of what they do on a day-to-day practice. These people came up to us afterwards and said, you know, I have never actually thought about what I do like that before. I'm actually thinking about it in a different way, the things I take for granted, because they were looking at it in this sort of, you know, mapped out way. Importantly, it fostered both horizontal and vertical organizational learning. So the map represents what ought to happen, but when you talk about it, you find out what really happens. By listening to each other, you find out, oh, is that what you do? Here's what I do. Or is that how you experience this system? This is how I experience this system. They were talking to each other, listening to each other for the first time, learning from each other about what they did. And of course, very importantly, it provided a mechanism to capture what you might call the lived experience of staff. And this resulted in them becoming very engaged in the process and feeling a sense of ownership. The last piece of feedback they gave us was, please, we don't like Excel. Could you do it as an online tool? Actually, all they had to do in Excel was click the file to open it, but it was in Excel and they were afraid of Excel. So they said, could you make an online tool? So an app is born. So we took those Excel prototypes and we used them for the basis of an online integrated tool that we call BPCLE tool, or B tool for short. We were able to introduce artificial intelligence into the tool to allow the tool to actually interpret those node ratings and review those, and then use that information to suggest items that you might like to include in an action plan, because this was a real hurdle people had, going from assessment into action planning. And it also suggested, Eureka, a subset of the 55 indicators that they might like to monitor based on where the problem areas were in the maps. We were also able to introduce reporting features, including single assessment reports and then comparisons, longitudinal comparisons over time, or horizontal comparisons across an organization. And of course, this outstanding collection of data, and we were able to give to the Department of Health and Human Services de-identified system-wide data. For the first time, they were able to look right across Victoria and say, what is happening in clinical education across the state? So today, the tool has more than 125 registered organisations using it. It's been implemented right across Victoria's public health system. They've been through the complete cycle of plan, do, review, and it's now being implemented in Victorian community health services as well as other health services, including privates and GPs in Victoria and interstate. So in terms of evaluation, the department wanted to know, how is this going? Do people like it? So they did some surveying at a couple of different points in time, and we were very pleased to hear that more than 80% were satisfied or very satisfied with the tool. More than 70% would recommend to another health service that they use this tool to implement the framework. And 80% rated the process very positively from the point of view of being a learning experience. And we got some lovely comments as well. And like I was saying earlier, people only publish their good comments, so that's all I'm telling you here today. But here's the last one. This one's important. This from a quality manager who sat in on one of our sessions. This is great. Could we use this method for other things that we do? And of course, we had started to think, well, maybe we could. And of course, every program, project, or process can be represented as a map. And we have been able to demonstrate that every logic model or process map can now be converted into an interactive tool, which brings us to meerkat, which stands for Map-Enabled Experiential Review Quality Assessment Tools, which is why it's a Q, not a K. So this is a meerkat base map. We don't call them process maps or logic maps because they could be anything. We can create a base map from a swim lane diagram, from a logic model, from any type of map that you can produce. They look a little bit different to how they look in the B tool, but this needs to be a generally applicable tool. We've changed the rating process, the assessment process a little bit. We now have a first step, which is where you poll all of the members of the group who are providing assessment, so you can actually record the individual ratings of the members of your team. You then go to a consensus rating and work out your consensus score. And finally, you work out, do you want to include this in your action plan or not? When you have finished rating your map, just like in the B tool, you can see instantly where your problem areas exist. We have a very simple Kanban-style action planning tool in there, where things that you rated not very well end up in your to-do list. You can then edit the actions that are suggested in there. You can add your own. You can give it a higher or lower priority than the tool is suggesting. And then you can move things into the in progress column and finally drop them into the done column when they're finished. And of course, there are reports that go with this tool as well, both single assessments, longitudinal comparisons, and also horizontal comparisons if you're implementing this across your organization. So the future of Meerkat, keep it simple, keep it accessible. It is accessible. It's a cloud-based tool. You need a modern browser and an interest in doing this, basically. So it is very accessible. But in terms of the simplicity is very important. One of the things that we learned from the B-Tool experience is that people engaged with the B-Tool because they didn't need a black belt in anything in order to be able to do it. The expertise they required was the expertise they already had, which was how they do their own job. What happens to them every day, how they experience their workplace. That's the only expertise they needed, and they applied it, and they enjoyed applying it. So keep it simple and accessible. We're currently working with a range of clients to develop both bespoke and general use base maps that are going to go into a base map library. So we're working with a health service partner to develop some maps that can be used by any health service when they're being accredited against the national standards. We're working with a large corporation that has a few customer service issues and they'd like to apply one base map right across all of their different business units. We're working with some consultants who, of course, do third-party process evaluations for clients. And then, of course, we'd like to develop some new features, some links to other software, particularly project planning software, additional user self-service functions so that you can use the tool without so much intervention from us, and what we call base map cascades, which is a little bit what we were talking about with DoView before, where you can click down to another level. So you might start with an overall program logic map, and when you look at a particular process, you can click down to a swim lane map that sits underneath that process, for example, if that's what you want to do. So in conclusion, our MER concept significantly expands the utility of program logic maps or process maps by converting what is essentially a static map into now an interactive tool, a tool that we've been able to demonstrate engages staff in the self-assessment and quality improvement processes, captures that tacit knowledge, that all-important evidence that is so rarely captured in evaluation about the realities of business process implementation. It provides structure to the important dialogue that must take place between managers and staff if you're trying to undertake quality improvement, and of course facilitates organizational learning. It contributes to the evidence base for your quality improvement action plan by actually showing you, diagnosing where are the problems and what are those problems. Not the low-hanging fruit, not the squeaky wheels, but where are the real problems as experienced by the people who actually do the work. And finally, of course, it provides a mechanism for monitoring your progress through quite a simple action planning tool. So I would just like to acknowledge that the development of the BPCLE framework and B-Tool was made possible through funding provided by the Victorian Department of Health and Human Services. And our web development has, for both B-Tool and Meerkat, has been done in conjunction with our partners, Python Charmers and Common Code. So finally, we do have a trade display booth here, Meerkat down at booth number 4. Vitas, Phil, Annie, and myself will be very happy to give you a bit of a test drive through Meerkat or answer any other questions that you might have. Thank you very much.
It's wonderful. I've never actually heard a crowd go, oh, like that before. It was amazing. Is Rosemary in the room?
Yes, Rosemary is here.
Excellent.
And it's all loaded up.
Okay, wonderful. Okay, so we've got about 5 minutes for questions. So if anyone has any questions for Donna? Yeah.
Donna, that was an amazing presentation. Thank you. You talked about how you there was a kind of set of metadata that went to the state government to be at one of your projects. Would you have any intention at any time in the future to create a set of metadata or a process that would enable each individual or agency to like benchmark or?
We have that in the B-Tool, and we plan to do that with Meerkat. So in the B-Tool, every health service can compare their own assessment data, but we're also now collecting indicators in the B-Tool, collecting indicator data, and they can benchmark themselves against de-identified data from across the state, and they can actually say, I want to only compare myself to other community health services or to this. So they can actually filter the data as well.
Great.
Yeah.
Any other questions? At the back.
I can see an application for something like this where we've already got various sources of information, a survey here and a interviews here or whatever, focus group results, and to be able to have a complex map and then click on it and somehow enter the results of other, not ask people to do it, but to enter results of a survey in there and so on.
Yeah, I forgot to actually mention that, but when I was showing the meerkat, one of the things that we've introduced is the ability to upload a file or to add comments while you're actually rating. So you can actually do that. And one of the things that we're sort of planning for the future is something that we're calling meerkat data, which would potentially have APIs linking surveys, so you could potentially have results from surveys even going straight in to the relevant node in a map, but that's all sort of a little bit into the future. But for now, you can certainly upload documents and record comments or notes against a node.
And then perhaps colour code, tick or cross.
Well, that's an idea for the future, for sure. But I mean, for now, you can certainly store that information and recall it at any time that you want to. Yeah.
Time for one more question.
Do you ever experience any resistance to yes/no answers? Because some people want to say, well, partly, or sometimes, or in this part of the organisation, but not that part, or whatever, and what do you do with that?
Okay, so what we've done with Meerkat that is different from bTool. So bTool does just ask you yes, no, and then if you say yes, it gives you that 5-point scale. We're about to convert bTool. Now that we've created Meerkat, we're about to convert it to a more Meerkat-like interface. And in Meerkat, we actually customize the rating scales for every single item. So we choose the most appropriate thing, and on the back, I didn't show you this, but come down and have a look. I can demonstrate for you. But on the item rating code, little dialog box, there's a little question mark. If you click on that, it flips the card over, and it tells you about this item, and it tells you what is the question that you're actually being asked to address. And then you can go, oh, that's why the rating scale says, twice a year as opposed to, so we're actually customizing now the rating scale, so they're more relevant to what people might want to answer rather than, as you say, yes, no, which is not always appropriate. Yeah. Come down to, to chat, yeah.
I will close this session
Fantastic.
now. Huge thanks to Donna. That was absolutely fascinating.
Thank you.